A patient tells you they're waking every 2 or 3 hours all night long. Their sleep study comes back normal. So what's actually waking them up? If you're a clinician, you've probably seen this scenario. At that point, many clinicians feel stuck. Sleep apnea has been ruled out, medications aren't really solving the problem, and referring for CBTI may not be appropriate for this patient. So what's actually going on, and what do you need to do next? In this video, I'll show you how I think about these cases clinically, and why fragmented sleep often has drivers that don't show up on a standard sleep study. I'm Dr. Nishi Bhopal, I'm a psychiatrist and sleep medicine physician, and on this channel, I teach clinicians practical approaches to evaluating and treating insomnia and other sleep disorders. This video is the first in a short series where I'll walk through the foundations of insomnia management for clinicians. Okay, so the first thing to understand is that one sleep study does not rule out sleep apnea or other sleep issues. I sometimes compare it to a single blood pressure reading. It's a useful snapshot, but sleep can fluctuate from night to night. It's also important to remember what a home sleep test actually measures. A home sleep apnea test is primarily a breathing test. It looks at airflow, oxygen levels, and respiratory effort. So it's useful for screening obstructive sleep apnea, but it does not evaluate many other causes of sleep fragmentation, like periodic limb movements, narcolepsy, or overall sleep architecture. In some cases, an in-lab polysomnogram may be needed. So when a patient wakes up every few hours, but their home sleep study is normal, it usually means we need to look a little deeper. So let me give you a quick case example. A patient came to see me because she was waking up every couple of hours throughout the night. She felt exhausted every morning, but her home sleep test had come back normal. She'd already tried several different medications, supplements, sleep hygiene strategies, but nothing was helping. So if the sleep study was normal, what was actually waking her up every 2 hours? At first glance, it looked like insomnia, but when we looked more closely, it became more obvious what was going on. Her breathing wasn't stopping long enough to meet the criteria for sleep apnea, but she was working harder to breathe during the night. So what she actually had was upper airway resistance. That increased effort to breathe was repeatedly activating her sympathetic nervous system and causing sleep fragmentation, even though the sleep study appeared normal. When we talk about sleep fragmentation, we're usually referring to the brief activations of the nervous system during sleep. Each surge of sympathetic activity can partially wake the brain. Your patient may not fully wake up or remember it, but those repeated activations break up the continuity of sleep. And many things can trigger these awakenings, including breathing disturbances, leg movements, pain, stress physiology, circadian disruption. So fragmented sleep is often a signal that something is activating the nervous system overnight. And one thing I hear from lots of clinicians is that sleep problems feel very time-consuming to manage in clinic. And honestly, most of us simply didn't receive much training in sleep medicine outside of a little bit of training in sleep apnea or maybe some basic training in insomnia. Even during my own clinical training, my sleep medicine fellowship, we spent a lot of time learning to diagnose specific sleep disorders, but less time learning a simple clinical framework for understanding fragmented sleep. So over time, through clinical experience, I started using a broader approach to evaluate these cases. And once you start thinking about sleep in this way, those mystery insomnia cases often become much clearer. Over the years, I started noticing that most cases of sleep fragmentation fall into 4 broad categories. These are food, environment, emotional factors, and medical conditions. If you're a clinician who wants a simple way to start evaluating sleep problems in clinical practice, I've put together a short free mini course for clinicians where I walk through the clinical approach step by step. So you can get that at intrabalance.com/doctors, and the link is in the description below. Okay, so let's look at how these categories show up in your clinical cases. The first one is food. This includes physiologic triggers related to metabolism and digestion. For example, reflux from late meals, alcohol or stimulants, excessive hunger overnight, hypoglycemia, nutritional imbalances like low ferritin or B12. These factors can activate the nervous system during the night and cause fragmented sleep. Environment plays a surprisingly large role in sleep continuity as well. This includes things like light exposure, noise, temperature. Irregular sleep schedules and circadian disruption can fall into this category also. Sometimes the cause of fragmented sleep is surprisingly simple and obvious when you look at it. So I was once staying at an Airbnb where I kept on waking up throughout the night, and I couldn't really figure out why. I wasn't stressed out, the bed was comfortable, I'd gone to sleep easily, but I kept on waking up. Then I noticed there was a bright outdoor light shining directly through the bedroom window. So my husband ended up going outside in the middle of the night and unscrewing the bulb so the room could finally get dark. It was a simple fix. So experiences like that are a good reminder that we need to ask patients about their sleep environment. So one simple question I often ask patients is, what does your bedroom look like at night? Is it completely dark, quiet, and cool? Another category is emotional or psychological activation. This includes things like anxiety, stress, rumination, trauma. Over time, the brain can actually learn to stay alert at night, something we call conditioned arousal. This is a common driver of chronic insomnia. And finally, there are medical causes of sleep fragmentation. Examples include chronic pain, endocrine disorders, restless leg syndrome, periodic limb movements, sleep apnea, narcolepsy. Clinicians often start here, but many patients actually have multiple drivers across categories contributing to their sleep fragmentation. Another example that I see often is patients with restless sleep due to low ferritin. Their sleep study may be normal, but they're moving frequently or feeling restless during the night or waking up repeatedly, or they may not be aware of those awakenings. Once that iron deficiency is addressed, their sleep becomes much more stable. I see this time and again in my practice. So sometimes a simple physiologic factor can explain a problem that initially looks kind of complex and intangible. So the key insight is this: fragmented sleep usually isn't random. There are almost always underlying drivers activating the nervous system overnight. Once you start looking systematically across these categories, many of these cases become much easier to understand. In my clinical practice, we often see patients who have been told that their sleep study is normal, but they're still waking up throughout the night. When we begin addressing these drivers, many finally start sleeping through the night again. So many of these cases ultimately lead us back to insomnia physiology, because chronic insomnia often develops when the brain becomes conditioned to stay alert at night. In the next few videos on this channel, I'll walk through the foundations of insomnia, including how insomnia develops, how to evaluate it in clinical practice, and practical treatment strategies that you can use as the clinician. Sleep fragmentation with a normal sleep study is extremely common, and many clinicians feel stuck when you encounter these cases. If you found this video helpful, consider sharing it with a colleague who sees patients with sleep problems. It may help them think through these cases in a new way.